Good morning, ladies and gentlemen. My name is Tariq Al-Tawil, and I'm one of the orthopedic surgeons at the National Institute of Neuromotor System in Cairo. This is a case report of a lady, 26 years old, who was given a total hip replacement and had a revision on top of neglected fracture dislocation. This is the injury x-ray of a 26-year-old lady who fell from third floor, sustaining this fracture dislocation of the right hip with fractured distal radius, as well as you are going to see. And actually nothing much was done apart from a back slab for the rest and skin traction in bed for a few weeks. This is when I saw her first time. This is the x-ray of the hip, as you can see, and the distal radius. And actually with this early union, and in that time 24 years ago, my plan actually was to give her a total hip replacement and to delay the operation up to 6 months till full consolidation of the bone, and then I may do a cemented total hip and use the head as a graft and graft the acetabular defects. So definitely a CT scan by that time was done to see the nature, more details about the nature of the fracture, and as you can see here, the head is still contained in the shattered acetabulum. So the plan was to keep her for another 3 weeks in traction in the hospital, go home and continue traction for another 3 weeks, then start partial to full weight bearing for 3 months, making it a total of 6 months following the injury, and then do a cemented total hip. The idea of using a cemented cup is after grafting the acetabular defects and with the cement mantle, you can to some extent negotiate with the head, with the acetabular component, whether slightly anteriorly, posteriorly, up or down in the best position within the cement mantle, a thing that you cannot do with cementless cup. So this is the operation which was done, and as you can see how we used the head in a nice imbaction mercerized grafting in the all around the acetabulum actually, and then the cement mantle and the acetabular component fixed nicely with good angle and good angle of antiversion as well. And these lines can show you that the femur was brought almost down to length, comparing the two lesser trochanters, while the center of the hips, the prosthetic one may be slightly, the center is slightly higher than the normal anatomy. This is 2 years follow-up, 25 months, as you can see here. I apologize for the quality of the x-ray, but unfortunately by that time this is the only x-ray that I keep from this long time. And as you can see, everything is still in a very good position. And this is a lateral view, the same period, 25 months following the operation. She was doing quite well up to 5 years when she fell in the bathroom 2 successive times with a few weeks apart, and unfortunately this led to damaging and loosening of the acetabular component. a decision of making a revision with a cementless components was done. And this is the X-ray in the time in by the end of 2003, and you can see the damage of the acetabular component and of the graft that we've done as well after 5 years. And in this situation, definitely she needs a revision. And by that time, we had two options: whether to regraft this acetabulum with these large defects, whether using autogenous or heterogeneous grafting, and the other option is to use an extra large cementless cup, or what we may call a jumbo cup. And actually the second choice was my choice. This is a 3 months old X-ray following the revision, and as you can see here that the this large or extra large cup which was used actually has no central cover. Is protruding into the acetabulum, and actually because we didn't use graft, and we hope that new bone may form over the cementless surface here. And we used longer revision stem as well. But 3 months following her revision, she was doing well. She is standing on the operation side, and she has flexion more than 90 degrees. And this is 1 year post-op. I believe everything is still in very good position. And here you can see her squatting and sitting quite comfortably. And this is 9 years post-op. Still, I would say no much change. And this is the lady 9 years standing on the operation side and on the healthy side, and showing her wrists. She didn't like any further intervention regarding her old wrist fracture. And this is the lady while walking 9 years following her operation. I believe doing quite well. Ten and a half years down the line, I believe still everything is in place, and though the center of the prosthetic hip is higher than the healthy left side, yet from a clinical point of view, she was doing quite well. And this is how she walks after 10 and a half years. I believe this is a very good clinical result for her. And this is now 13 years follow-up. No much change actually, as you can see on the AP and on the lateral views. And this is 16 and a half years, still no bony cover of the medial aspect of the acetabular shell, which is protruding into the pelvis. Yet, from a clinical point of view, she was tolerating quite well and performing very nicely. She was complaining of some low back pain. She had these x-rays which showed some sacralization of lumbar vertebra number 5, as you can see, and with this pseudo joint which could be painful or maybe the cause of her low back pain. This is how she used to walk 6.5 years following her revision. I believe this is an excellent result. Now 18.5 years and still everything is in place, no much change, and still the acetabular component is not covered by bone medially, but there is a good increase in the density of the bone at the weight-bearing area, and you have further x-rays here, or other views showing what I'm saying, with the new bone formation surrounding the stem, making it to fit quite snugly. And this is the lateral view, as you can see, with the stem fitting quite well into the femoral medullary canal view. And this is now the lady after 18.5 years of her revision, and as you are going to view her while walking. So the message from this case actually is what I would deal with neglected fracture dislocation is not to intervene with a total hip quite shortly after the fracture dislocation, but I believe, in my belief and with many cases that I've done, it's much better to leave the fracture to consolidate. So when you do a total hip, it will be easier, and you have good stock of strong bone to hold your prosthetic components. And if you are going to do a revision and you have large acetabular defects, in my belief, it's better to use a extra large cup. And even if you have a problem in many years to come, you may, by the time matters would be easier in the future, and choosing a mega or jumbo cup is a good choice. Thank you very much for listening.